seem to recall. Actually, it's not followers on YouTube, it's subscribers. Yeah, I'm live. You know, I've got literally hundreds of followers on YouTube. If you're not following me on YouTube, for goodness sake, I can't believe there are people out there actually who aren't following me on YouTube, because as I say, there's 700 of them out there. But if you're not, then please do follow me on YouTube. And my YouTube name is Staiano Clinic, I think it's called, or the Staiano Clinic. Dan has got a dermatologist appointment today. You got a appointment. So Dan, I'm guessing you're not in the UK. I'm in the UK, and it is currently 7:20. I mean, you could, I guess, have a dermatology appointment today, but I'm guessing it's not morning where you are. I mean, it's not evening when you are. Oh Lord, I've been on holiday for 2 weeks. Bear with me. I've trying to get back into it. It's a struggle. So I got some questions. So Dan's in the US. I've got some questions lined up. If you have any questions, then please feel free to ask away. I will do my level best to answer them as best I can. I will kick it off if that's okay, because I can't see anything going on at the moment. I'm assuming, right, Dan, obviously the audio is working on Instagram. I'm assuming the audio is working on Facebook. I don't know how I can tell. If it is working, say it's working on Facebook. If it isn't working, sometimes no one says anything on Facebook, so doesn't necessarily mean it's not working. I mean, clearly, I know there's a silent majority out there on Facebook. I know it. It may not appear in the stats, but I know it's there. But you would say something if this guy was not. Anyway, we're going to assume it's working. That's it. Right. Sorry. So first question number one is this question right here. Have I got Mondor's disease or Mondor's cord? Mondor. Something out of Lord of the Rings, isn't it? Mondor? Mordor. So question goes something like this. I had an augmentation back in February. I had no issues and healed very quickly. I have since, however, noticed that when I lift my arms up, my right breast looks different to the left and sits strangely, and have a pain in my right breast when I lift it up with my hand, with a vein that sticks out and feels a bit painful. As you do, I started Googling like mad, lol. Lots of things online say it's called Mondor's disease or Mondor's cord. Do you think I should come in to get this checked out? I'm a bit worried about it. Have I got Mondor's disease or Mondor's cord? So it sounds like it, yeah. Oh, David's... Oh, it's working. So, oh God, what? Oh God. Right. You don't need to see this, David. This is not for you. Let's get that comment off there, please. Hello, David and Mum. I'm very famous now, and as you can probably see, there's quite a lot of engagement. So you can move on now. Oh God, that's awkward, isn't it? Got my mum on the line. Right, so Mondor's disease. Yes, sounds like it. Well, certainly the cord bit sounds like Mondor's disease. This lifting your arm up. What does it say? I lift my arm up and this sits strangely and pain in my breast. So lifting the arm up and sitting strangely is not necessarily Mondor's disease. What Mondor's disease is my mum will probably have something to say about that, but you know, we know what I'm saying. We know what I'm talking about. It is a blocked vein in the just underneath the skin, superficial vein, and you can sometimes, when you lift your arm up after a breast augmentation, get these things like cords. It's like a piece of string, and it can be a bit uncomfortable when you lift your arm up where the incision is, and it's either a vein or a lymphatic that has been damaged by the incision, because obviously the incision has to go full thickness through the skin, because you have to sort of make a space to put the implant in. So you are going to damage some veins. That's not a sort of complication, that's a necessity. There's going to be some small vessels which are going to be divided when you put the implant in. That happens every single time you do the surgery. But sometimes those blocked veins, you can get a bit of superficial infection. It's called thrombophlebitis. It's just infection in the vein. in that blocked vein, and it can feel a bit hard. You get a similar thing when you have drips. Sometimes you get a bit of a blocked vein from a drip in your hand, and it can be a bit uncomfortable and it can go hard, but we will recanalize. The hole will come again, the vein will come again and become a normal vein again. It will, the body's fantastic at doing that, but while it's doing that, it can feel a bit uncomfortable, and particularly when you put your arm out, it can feel a bit tight. The other thing it could be is that when we do the surgery, or at least when I do the surgery, I close the surgery in 3 layers, and the deep layer is a layer of what's called fascia, which is quite sort of quite tight white tissue, which is overlying the muscle, and it holds the stitch well, and it's a very deep layer that closes the pocket up so that the implant doesn't have any communication with the skin. And then there's 2 more layers. There's a layer right underneath the skin and then a layer in the skin. So there's 3 layers of sutures. But if you close that very deep layer of that fascia tightly, you might get a bit of a line there as well when you lift your arm up. That might be another reason for that same symptom being the line. So the symptom is like a line or a cord, or it feels like a piece of string there. It's nothing to worry about. If it's uncomfortable, you can have anti-inflammatories. Some people feel like putting hot compresses on and things like that can help with the inflammation. If you have just had your breast augmentation, this patient's had it in February, but if you have just had it, then you've got to be a bit careful with the sensation, because if you've got abnormal sensation on your breast and you start putting hot and cold things on there, you could potentially burn the skin if the sensations feels abnormal. So just be a bit careful about that. But it's a self-limiting thing in that it doesn't need any treatment and it gets better on its own, and it's totally nothing to worry about. It sounds quite dramatic. Mondor's disease sounds like it's, I haven't put this question. Mondor's disease sounds like it's quite dramatic, but it is nothing to worry about, and will get better on its own. So that's what it is. Certainly that's what that cord is. The fact that you the other thing is when people say, oh, when I put my hand in the air, my breast goes a funny shape. I'm like, well, I don't know if these implants are under or over the muscle. Certainly if they're underneath the muscle, sometimes the implant can go a funny shape because the muscle's sort of pulling up. But I often get people who send photos and things, say, look at me in this position. My breast looks all funny when I'm all in this position. I'm like, well, things do get funny shapes when you're in funny positions. And if it looks okay at rest when you're standing like that, then I'm sort of probably going to be okay. I mean, the bottom line is I'll see this patient. I hope we've contacted her and said, look, I'm happy to see her because she's my patient, and any patients of mine are very happy to see at any time, and I'll check you out and make sure what's what. But when someone says, oh, look at this, I've got a funny bulge when I do that, if it looks okay when you're at rest, you've got to be a bit careful trying to correct that, because if you correct that so that it looks normal when you're doing that funny move, when you're at rest it might look weird, and it's more important that it looks okay when you're at rest. So I'm not that worried about it looking a strange shape when you put your arm up, because it just might be the muscle pulling it up, assuming it's underneath the muscle. Bit painful. I mean, it's February, the surgery. What are we now? God, we're September. Can you believe that? We are September. Oh my God, Catherine McLeod's here as well. Oh my God, what is going on? Is this who the people who watch this is? I thought it was patients who watch this. David Staiano, Catherine McLeod, and my mum. Is that what the stats are made up of? I was convinced it was members of the public who watch this. Anyway, I'm going to push on. I think there might be members of the public out there as well. So yeah, the bit painful thing, I mean, I can't believe it's February. It's September, February to September. That's 6, 7, 8, 7 months. So it might still be a bit uncomfortable. But anyway, so, all in all, not particularly worried about that. And Mondor's disease or Mondor's cords are something that happens. It's not unusual. Well, it's not that usual, really. I would say it's not unusual, but it can happen after a breast augmentation. And it's nothing to worry about. It's just like a little cord, like a little string there. I think we've dealt with that one. We've had someone ask a question here on Instagram. Can you do consultation and minor surgery on the same day? Yes, Candy, I can. That's one of the beauties of having my own clinic. I've got my own clinic. I've got my own operating theatre. So pretty much, broadly speaking, in the clinic, well, certainly at the moment with all the isolation and everything, there's only one surgeon at a time at the clinic, and so the operating room is free. pretty much. So we do. It's not like when I do stuff at the hospital, because the hospital also has a minor ops room, but they tend to have lots of surgeons there, so they tend to book the minor ops room. So you have to book a session in the minor ops room. So if someone comes with a mole, I have to then book a session in the minor ops room to take it off another day, sort of thing. But because I've got my own minor ops room in my clinic, it's always free. Not very efficient, but it's certainly good for patients, because if you have a mole, or if you have a cyst, or if you have a any of the minor procedures we do, split earlobes, inverted nipple corrections, areola reduction, anything that we do under local anesthetic, we do it there and then if you want. So it's called a see and treat. So we would do it you would book it in advance. You would let us know that you wanted it done, because we'd obviously have to block out enough space to do it. But it's a see and treat service, so we can have it done on the same day. There's no obligation to proceed. We do take £100 deposit for those consultations, but we will refund the consultation if we don't do this procedure, either from something that we said to you, either from your point of view or from our point of view. If there's any reason that we don't do it, then we refund that. But yeah, it's good. It's good. I think see and treat's good service. Dog, yeah, dog tick. There it is. What's going on? Someone coming to the door? No. Push on. Okay. Oh God, sorry. Leonie, are infections or complications really common after surgery, especially breast surgery? No, Leonie, they're not. I don't know what you're going to say. You would say that, wouldn't you? I mean, I wouldn't say that, Leonie. I would tell you if there were complications were common. Now, I would say it depends on what surgery you're talking about. So I'm assuming you're talking about cosmetic breast surgery rather than reconstructive breast surgery. So that's sort of the two big areas, really, in terms of breast reshaping. You have a cosmetic work, which is people for breast enhancement, breast lifts, breast reductions, that sort of stuff. And you have reconstructive work, which is people who've had breast cancer, who have had a mastectomy. Usually they might have had a wide local excision, but they had part or all of their breast removed and reconstructed. So yeah, breast reduction surgery. Okay, so that's cosmetic breast surgery. So in reconstructive breast surgery, there's often other treatments that have been used for the cancer, like radiotherapy and chemotherapy, and they can affect your ability to have a good wound healing. So your risk of complications and wound healing problems are increased in breast reconstructive work. But in cosmetic work, like for instance breast reduction, the risk is less. Now, I've got to be honest with you, Leonie, a breast reduction is quite a big operation, and there are risks of complications. Now, the things that I would say are maybe not common, but you can have a good chance of getting, would be delayed wound healing and breakdown, particularly at the T-junction where the two scars meet down here. So you might have a delay in the wound healing. We aim for the wound to heal in a week to 2 weeks, but sometimes it can take longer, particularly at that T-junction. So that is, getting on for, I would say, common, a little bit of wound healing problems. Now, usually it's not infection. Often what happens is people go to their GP, the GP says it's infected, gives them antibiotics, and they say, oh, that's great, it's got better. It usually doesn't need antibiotics, it's usually not infected. It's often quite red, but that's normally just inflammation, and it's just a bit of wound breakdown, because that is the tightest point of the closure, because when you do a breast reduction, a breast lift is part of it, so you're tightening the skin envelope, and so that can be really tight, that point of the T-junction, and so sometimes you get a little bit of wound breakdown there, and that might be an issue. It could get infected, as I say, it often isn't infected, but it can get infected secondarily. But it usually just needs antibiotics. Now, whilst the breast reduction is a bigger operation than a breast augmentation, so breast implants, which is, I guess, the other big sort of group of operations we do on the breast, if you get an infection, if you get a problem, it's less of a worry than when you've got implants. When you've got implants in, it's a little bit more of a worry in terms of breast infections, because if you've got an implant in and you've got an infection, that's a significant complication, because antibiotics won't treat it. You have to remove the implant. Whereas if you haven't got an implant in, antibiotics will treat it, because antibiotics run in the bloodstream and an implant doesn't have a bloodstream. So if you've got an implant with infection on it, the antibiotics won't get to those bugs, because they're just sitting on that implant, and they will never go until you remove that implant. But that's one of the benefits of a breast reduction. So whilst I would say it's probably got more risk of getting problems, particularly in terms of wound healing being delayed, it's less of an issue than it would be if it was an implant there. But yeah, you have to be prepared for the complications and for the aftermath. Is that the right word? After, what will happen after surgery, because it is quite a big deal having a breast reduction, and it will knock you back, aside from the complications. And obviously there's always risks of complications, but the complication rate isn't high for cosmetic breast surgery in general, to be honest with you. Otherwise it wouldn't be so popular. I think people have this perception that people are having problems all over the place, because I think quite high botched. I mean, there's a program called Botched. I mean, how helpful is that? Plastic surgery nightmares. That's all you see on TV, isn't it? What else? Anyway, they're all basically want to know about all the terrible things that have gone wrong. That's what the media want. That's what the media portray plastic surgery. Oh yeah, it's all gone wrong. Oh, it's all rejected my implant. Oh, it's all, But actually, in real life, it isn't like that. Trust me, I'm a doctor. It really isn't like that. If it was like that, if there's people having all complications all over the place, it wouldn't be as popular as it is. There are complications because a lot of surgeries are done, but in terms of the statistics of it, it's very low, the risk of complications. But it's out there, so you have to weigh it up against the benefits of surgery. And if the benefits of surgery are not that high, then maybe you think, crikey, I'm not going to have it. But if the benefits of surgery are high, maybe you'll accept some risk of complications. There are Facebook groups to which make me wonder. I got an idea about that, Leonie. I think the thing about, and you're right. I'm sure I know there are lots of Facebook groups where people have problems. They get together. I think the issue is, and I think what you'll find is that if someone has a good result and is happy with the result, they tend not to make a Facebook group together. They tend not to sort of go on about it much, really. But I think if someone has a bad result, then their post-operative care is prolonged. They need a lot more support, both from the surgeon and from other people. And that's why they make Facebook groups, join Facebook groups. They get support from each other. They get help from each other because they might need further surgery, ongoing surgery, and it's a much more protracted post-operative course. And that might skew the appearance of surgery in that there's probably hundreds of Facebook groups about things that have gone terribly wrong, whereas very few Facebook groups of like, oh, I've had a good surgery, breast implants, and I'm happy with them. The breast implants and happy with them Facebook group is not very well attended, although there's a lot of people out there with that, but they don't need the help, the support, and the sort of camaraderie that you get from the community on Facebook. And I think that might be why there's a bit of a skew towards it. But I think it's about having a balanced view, Leonie, and being aware that there are certainly bad things that can happen. That there are certainly, it's certainly a big op that can knock you back, but just putting it in perspective. Kim, is there anything I can do pre-op to prevent necrosis? Yes, I'm the type who has joined all these groups with regards to complications, and it's frightened the life out of me. Kim, necrosis, are we talking breast reduction again? Necrosis is that's a bad word, Kim. Where'd you get that word from? Oh, we don't like that word, Kim. I mean, necrosis is death, skin death, necrotic. And it depends what you call necrosis. I mean, if a bit of skin dies, yeah, then the skin gets necrotic. So what I've just said about the wound breakdown at the T-junction, well, you could say a little bit of skin could die there, because if it's healed to start off with, and then there's a little hole there, that skin might have died, but it's a small amount of skin. You wouldn't really call that necrosis. Certainly in terms of the breast reduction, if we're still on breast reduction, necrosis is I'm thinking more of the nipple. That's the thing we worry about, necrosis of the nipple. So a nipple can die when you do a breast reduction. So the things that you can do, Kim, preoperatively to prevent necrosis are eat healthily, get your weight right. If you're overweight, you got I've seen so many on tummy tucks around the nipples. Yeah, tummy tucks as well, because the skin's really tight. Necrosis comes up on those bad groups a lot. I might leave them, as I do want the surgery, but they can scare you. Yeah. Does it come up a lot? Yeah, I mean, necrosis doesn't come up a lot in practice. it's not something your average plastic surgeon will see very often. I mean, your average plastic surgeon will be able to deal with it, and we see it a lot when we're in the hospital, and we've got people who've had bowel surgery, and all sorts of people are ill and had necrotic wounds because they've been very run down. But in cosmetic surgery, you want to optimize people. So I do think it's important to get your weight right first. If you're overweight, you're going to increase your risk of complications. Smoking is a nightmare for necrosis, to the extent that if you're having a surgery where you're closing the wound tight, any sort of body contouring, breast reduction, mastopexy, which is a breast lift, tummy tuck, facelift, arm lift, thigh lift, all these surgeries, all the body contouring surgery is by definition closing that wound tight. And anything that will reduce the blood supply to the skin is going to increase the risk of that wound opening up. And if it's really closed tight and it opens up, it can be a nightmare. And the only really big nightmares that I've seen have been in smokers. Smoking is a nightmare. And so therefore, if you are considering any of those sorts of surgeries and you smoke, I would say to you, you're better off not having the surgery if you can't stop smoking. And I know what you're going to say. Oh, you got it in for smokers. Oh, equal rights for smokers. We should be allowed surgery and all that. I'm saying it for you, because if you have one of these necrosis, you'll see it in your groups. It is an absolute nightmare. And so I'm not saying it because, it's not, we say the same thing in the NHS, and then you get shot down when you say it in the NHS, because people say, oh, I pay my taxes, I should be having surgery. It's nothing to do with paying your taxes. It's nothing to do with paying the surgery. I say the same thing in the private sector. So even if you're paying me for the surgery, I'll say to you, no, I don't want you to pay me for the surgery. I don't want to do the surgery. If you smoke and you want a breast reduction, breast lift, tummy tuck, facelift, anything like that, I would say don't have the surgery. So anything you can do is to stop smoking, ideally 6 weeks before. The really critical time is at 2 weeks from the day you have the surgery to 2 weeks afterwards to get that wound healed. If you smoke, it's a disaster. So smoking is a bad thing. Getting your weight right first, good diet, healthy diet, balanced diet, and positive mental attitude. I know it sounds airy-fairy. I know it sounds a bit iffy, but I really believe that it makes a difference. Shoot me down if you want, say it's not scientific and all that stuff. I really believe it makes a difference. I think, I think being positive, I think you have to know about all the potential complications. You have to know about the risks and make a balanced decision as to whether you're going to have the surgery or not. But if you've weighed everything up and you're going to have the surgery, I think you then need to be positive and not start focusing on the negatives and say, what if I'm going to get an infection? Or is this infection? I mean, obviously, give us a ring and say, is this infection? But don't it's infection. What's gone wrong? Oh, it's infection. I'm going to get the infection. I know I'm going to be the one. Oh, it always happens to me. I know I'm the one who's going to get a necrosis and I'm going to get this and that. Don't be like that. Don't be like that. Say it's going to be great. I'm going to have a great. Honestly, I see it. These people who are positive, who are just they have a better result. I think the power of the mind, amazing. I do think it's amazing. I've seen stuff, and it really, I'm a believer. I am a believer. I am. Me and Anne Frank, we are believers. Honestly, the power of the mind. What about vaping, says Kelly? Kelly, vaping is not, vaping nicotine. Yeah, if you're vaping water, then, or whatever, steam, I don't know, then fine. But I think most of them have got nicotine in, haven't they? It's better than cigarettes, but it's not as good as stopping. So vaping is better than cigarettes. So again, it depends on the sort of surgery you have, and it's true for all surgery, but some surgery when you're closing the wound tight is worse. So something like a breast augmentation, maybe I'd probably be a bit less worried than say a breast reduction or a tummy tuck. The breast reduction, tummy tuck are bigger operations, bigger incisions, closed a lot tighter than a breast augmentation. So vaping is not good either, Kelly. You really need to stop. And we spoke about this a while ago about doing a test. You can do a test on people. And we spoke about this when I was in the NHS, but also in the private sector. But what I say to people, because obviously you can say, oh yeah, I've stopped. in order to get your surgery, but you're only kidding yourself. So you really need to stop if you can for those sorts of ops. That was a good question. Thank you for that. Jackie, nice to see you. I've got an agenda, as it were. Now, this question, don't know the context. I guess it doesn't matter. GA or LA and sedation. That's all it says. I've been away, so I've just seen. I don't know where. That's all it says. So, I mean, it depends on the surgery. Oh, here we go. Kelly stopped vaping. Well done, Kelly. Nice one. 2 weeks in. Awesome. Keep up. You giving up vape? That's the thing, isn't it? People giving up cigarettes now. We're giving up vaping, but that's good. Well done. Keep it up, Kelly. Keep it up. So I guess it depends on the surgery for this, and it also depends on the surgeon. Well, and the patient for a start. Well, yeah, it depends on all things. God, I haven't thought this through, have I? So it depends on the surgery, the surgeon, and the patient. So, I mean, some surgeries are bigger than others. So tummy tucks are a bit bigger. Breast reductions are a bit bigger than, for instance, mini tummy tucks or breast augmentations or mastopexies. So mini tummy tucks, breast augmentations, mastopexies is a bit more amenable to a local sedation than a full tummy tuck or a breast reduction. Having said that, you can have a full tummy tuck and a breast reduction under local with sedation, but it's just the spectrum. It just sort of weighs the balance more towards the GA. So it depends a bit on the surgery. Some surgeries are a bit more invasive than others. It depends on the surgeon, so on the surgeon's experience and whether the surgeon's comfortable doing LA and sedation. I've got to be honest. I think the world, well, I think the UK is moving more towards LA and sedation. I think America moved towards it a while ago, but I think we're moving more towards LA and sedation. And so I think as surgeons, we are becoming more comfortable with it. And I'm certainly doing more. I haven't done a huge amount, but I've done quite a bit under local and sedation. I've certainly done big ops, tummy tucks, breast lift, mini tummy tucks, obviously breast augmentation, so but it depends on the surgeon has to be comfortable with it. And the other thing was, what did I say? Oh yeah, the patient. So it depends on the patient. The patient's got to be up for it. So I personally, I don't really push it, but I think most things could be done under local and sedation, but the patient has to be. If the patient's like going, oh no, oh God, don't fancy it, then fine, GA, no problem at all. The expertise required for the surgery is similar. You still need an anaesthetist. You still need a lot of the equipment that you need for a GA. So, the setup is similar, and arguably the anaesthetist has to work harder for a local and sedation case than they do for a GA case. So if the patient wants it, certainly the recovery can be easier, can be better if it works. And sometimes what we do, we do a local and sedation with a view to doing a GA. If it doesn't work well. And what we're doing now, particularly in the COVID-19 era, is, to be honest with you, I'm going to be frank now, we're struggling to get into theatre, to be frank with you. The hospitals are being used a lot by the NHS, and the private work that they are doing, they are not prioritising plastic surgery at all. So as plastic surgeons, we're all a bit disappointed that we can't get our patients into theatre. And so that is where local and sedation is becoming a bit more attractive, because it requires less of an operating setup in order to do local and sedation. So plastic surgeons and other, well, I don't know, maybe other doctors are doing it, but certainly plastic surgeons are getting setups where they can do local and sedation in their clinics. I haven't got that set up in my clinic as of yet, but that is something that if you wanted local and sedation, it's something that you could potentially get your operation done before having a GA. But that would be you'd have to be comfortable with it, because I think we're gonna. I don't know what's going to happen, to be honest. It's going to be interesting whether we move into a situation where we actually don't need the hospitals anymore. Because to be frank with you, we don't need a huge hospital setup for a lot of the work that we do. If you're doing orthopedic work, or if you're doing bowel work, you need the infrastructure of a hospital, but a lot of plastic surgery doesn't need that infrastructure because it's all soft tissue plastic surgery. So I wonder whether that will be a movement in that way. And certainly local sedation will probably become more common. I think it already is, to be honest with you. But yeah, it depends on so I haven't thought that through. It's a triad on the patient, on the surgery, and on the surgeon. What's going on? Thank you. I always feel better once I've heard what you've got to say. That's from Kim. Thank you, Kim. Leonie, what sort of pain meds do you need post-op for reductions? I have had codeine in the past, but did not like the lightheaded feeling. Would paracetamol be enough? Good question. Oh, and Susan's asked a question there. So, good question, Leonie. I like, and I put this on my post-op instruction sheet, I like paracetamol and ibuprofen, normal painkillers you can buy at the chemist. I like the normal ones. We do some, and again, breast reduction is soft tissue, so it's all skin and fat. We're not cutting through any muscles. We're not going into deep body cavities. So yes, it will feel tight. Yes, it will feel uncomfortable, but hopefully it won't be too painful. And I like just paracetamol and ibuprofen. If the pain's worse, we have got stronger painkillers like the codeine ones you're talking about. But you're absolutely right. They can make you feel lightheaded. They can make you feel sick, and they can make you feel constipated. So they do have potential problems associated with them. So I would say only take them if you need them. I just realized my speaker's turned off. Does that matter? Only take them if you need them. I'm with you on that one, Leonie. I don't like the codeine-based ones. Don't like them. Susan's in the house on Facebook. Thanks, Susan, for making a comment. My mum's, well, she was here earlier, so it's nice to see that there are some people who engage with my Facebook Live. So thank you for that. How soon after thigh liposuction do you feel mobile? Can you get up and walk about straight away? Yes, Susan. One of the complications of this sort of surgery, of any surgery, but particularly surgery when you're sort of making the legs tight and you're going to be immobile for a period of time, is DVT and PE. And that's something we worry a lot about. DVT is a blood clot in your legs, and the PE is when that blood clot flies off into your lungs. And that happens after any period of immobility. So it is a risk after surgery. And we're really worried about that. So there are things we do. We put these things on your calves and we get you moving your ankles and things. But really the best thing you can do to prevent a DVT is to walk. So we do try and get you up and about straight away. Probably not the day of surgery. You're probably not going to feel like it. It's quite a long operation and you're probably going to want to rest that day. Unless it's done early in the morning, maybe later on in the evening, you might feel like getting up and just sort of walking to your chair or just moving around your room. But certainly the next day will get you up and get you walking. Now, we're not talking about craziness. We're just talking about walking around your room, pottering, going to the loo and things like that. But yes, we do try and get you up. Oh, sorry, thigh liposuction. I thought it was thigh lift. Oh, thigh liposuction, even less invasive, Susan. Yeah, thigh liposuction, you'll probably be up that day. Sorry, I thought it was thigh lift. Yeah, you'll be feel mobile probably that day, Susan. Well, depending on how much, unless it's a huge volume of liposuction. But it is good to get you mobile straight away. So hopefully that day, but if not, certainly I would say the next day. And then, you go home and you'd be pottering around the house. So we would try and get you up and about and get you moving. Yeah, good. That's good. I thank God I've got some questions because I've got to be honest with you. I haven't got many questions on my agenda, which I'm a little bit disappointed about because I'm only away for 2 weeks. I mean, you think you'd have more questions, but anyway, we won't dwell on that. Right. Which procedure? Right. Here we go. Look at this. I have what I hope is a quick question to answer at this point. I'm interested in getting some facial moles removed and also have some wrinkles under and above my lips. Under and above my lips and on my forehead, which I want sorted out. Which procedure is best to do first? Facial moles removed and some wrinkles. Which procedure? Oh, Susan, you're welcome. You're very welcome. I don't know. I guess I don't think it matters. I can't see how it would matter. I mean, I'm assuming your wrinkles. I mean, obviously, I haven't got any wrinkles. Obviously, man of my youth, but you got wrinkles in the areas of the mole. Is that the thing? Doesn't matter. Doesn't matter. I mean, when we make surgery, when we make scars on the face, we put them in a line of your wrinkles. So obviously, if you've got wrinkles, we can see your wrinkles. So you could say, well, have your mole done first so you can see your wrinkles, so you can hide it in the line. Don't have your Botox and then you've got no wrinkles. But even if you've got, well, actually, yeah, that is the reason to do the mole first. Because I was going to say, if you've, what we do is you make the wrinkles like that. See where the lines are. See where the laughter lines are. I can't even make myself have many laughter lines. Does my face look all red? Yeah, I've just answered my question. Do the Botox after the moles, because you want to see where you want to see where the lines are. And if you have Botox and you can't see the lines, then yeah, mole first. There you go. I wish I'd thought about that question a bit more before I came on, but there you go. Mole first. Assuming the wrinkles are in the area of your mole. If your wrinkles aren't in the area of the mole, then it doesn't matter. Do people send you questions during the weeks for the live videos? You'd think so, Leonie. You would think so, yeah. But I haven't had many questions. But yeah, you can email me a question, Leonie. You can Instagram me on the messages, or Facebook messages. You can message me with the questions. But yes, you are well, or you can just do it live. You don't have to send it before. You can just do it live. I'm happy either way. As you can see, I haven't put any preparation whatsoever into the ones that have been sent before, so it doesn't make much difference. Right, scars. Following tattoo removal, I was told the scar will be long. To be honest, I'm more afraid of keloid scarring or hypertrophic scarring, and the scar being thick or not straight lined. With regard of the location and stretching, is there nothing that can be done to avoid it? Right, this person is a person with a tattoo. They've got a large tattoo here. I haven't got evidence that they have allowed me to show the photo, so better not. So can you send a picture? Yeah, you can send a picture, Leonie. I love it when you send a picture because it's much better with a picture. Yeah. And if you let me show the picture, I'll show the picture on the thing and talk about it on this. I have that facility, especially on Facebook, but I have to turn the camera around on Instagram. It always looks a bit rubbish. But anyway, I can do that. Actually, I think I can show. Can I show a picture? Questions from your viewers will be shown here. Oh, I should have put that ask a question thing, shouldn't I? Where's that? Go live with. Anyway. No, I'm not going to do it now. So, oh, is that photo? Oh God, do that. Oh God. Oh God. What? Can you see that photo? Sorry, did you see that photo then? My wife's going to kill me. That was a photo. Right. Anyway. Right. So this patient, yeah, big tattoo here. So they're worried about keloid. Now they have got dark skin. Keloid scar is more of a risk. You saw that photo, did you? Oh dear. Sorry about that. Right. Anyway, it wasn't too bad, was it? Okay. Well, anyway, at least I can know that I can show photos on Instagram. There you go. I've proved the point. That was my little boy trying on a hat at the antiques flea market yesterday. Was it yesterday? Yeah. So he bought it as well. Like a deer stalker. Anyway, didn't see a photo. No, Susan, that was on Instagram. I'm actually a multimedia celebrity when it comes to my social media. My social media reach knows no bounds, and I'm on Instagram and on Facebook. And I know I can show photos on Facebook, but I've just realized I can show Facebook photos on Instagram as well. So yeah, it wasn't very interesting. That it was just a photo of my little boy putting a hat on, and he wanted to see what it looked like from the back, so I took a photo of him. So it wasn't really one for the photo album. It was just anyway. So this patient is worried about the scar, basically. So she has got darker skin, so has got high risk of keloid or hypertrophic scarring. Hypertrophic and keloid scarring are on a spectrum. They're the same sort of thing, and keloid scarring is just a worse version of it. Basically, it's lumpy, darkly coloured, like red or darkly coloured scarring, and it's ugly scarring. And it is a risk in darker skins. It's a risk in certain areas, so it's definitely a risk here in the sternum area, the chest, the shoulders. High risk there. You get it on the earlobe. So this sort of area is a real risk. This patient's got their scar here, so it's less of a risk. Bones going all over the place. So is that you, Leonie? Is that you on the? So it's less of a risk of a keloid scar. So I won't be quite so worried about that. But they're also worried about the scar being thick or not straight lined. I think. What about stretching? I mean, first of all, the tattoo is not straight lined. The tattoo is like a bend. But this is an issue with any scar. We always try and make scars straight line. It's like when you do an areola reduction, you're trying to make the nipple round. It never ends up round, I've got to be honest with you. And you try and make a scar a straight line, but healing, tensions of the healing and the scarring, bit more scar. You ever seen them with a tummy tuck? They go, oh, this bit of the scar is beautiful, can hardly see it. And then this bit of the scar is like really red. And you're like, well, why is that? I mean, so it's unpredictable how the body heals. Sometimes I think I would have liked to have been a woodworker, because I think if you're a woodworker and you measure it 4 millimeters, and then you measure a thing that's 4 millimeters, and then it all fits, or metal work, and you measure the hole and you measure that and it all fits, and it's going to work. And if it doesn't work, you haven't measured it right. The problem with surgery is you can cut it just like you want it, you can stitch it up, and you've just got this other dimension of time, of healing, that is unpredictable. And you look at the scar and they're like, why have you put the scar wonky? Why have you put this? And you're like, I didn't do it wonky. I did it perfect and it's gone wonky. I don't know why it's gone wonky. So it's just scar tissue. Yeah. So I couldn't guarantee it will be straight, and I couldn't guarantee it won't stretch. I mean, there are things we do to reduce the risk of stretching. Some areas are a higher risk of stretching than others. Certainly the back's got a higher risk of stretching. Also, it depends on how much you're taking out. This is a tattoo, as I recall, it's quite favorable. It's not too wide, and it's here, sort of underneath the breast on the chest. So it might stretch a bit, but and we try and put deeper stitches in, but even then, there's always a risk that it could stretch. And there's always a risk that it might not be straight. And what I would say in that circumstance is that if you are worried about the scar not being straight, about being a bit, a bit stretched, possibility of keloids, I would say, yeah, these things are all a possibility. And so your other option is to leave the tattoo. And if that option is acceptable to you, then maybe leave the tattoo. Because if you leave the tattoo, then you're not going to have any of these problems. If you have it removed, there's a risk it might not be straight. It might go keloid and it might get stretched. And it's awful, because I know people are like, well, can't you guarantee it? You're a surgeon. You should be able to tell me what I'm going to be like. And I've got to be honest with you. I can tell you that I hope it won't stretch, and I hope it'll be straight, and I hope it won't get keloid. But that's not helpful, is it? I can tell you that it's a low risk of keloid in that area. It's a higher risk in other areas, and I'll do everything I can to make it neat. And the scar won't be straight to start off with; it'll be curved, but I'll try and make it look nice. But it might not. It might stretch a bit, and it might not be a nice curve. It might, because the body and healing, bitter experience. What we're dealing with. It's a tough old job, I tell you. So, evening. Where have you been, Fee? What time is it? 8:02. I just had a comment on YouTube. Look at that. Comment on YouTube. Look at that. Oh, God, here we go. Got a comment on Instagram as well. I am really flat-chested. I'm not even a 32A cup. Is it still possible to get natural-looking breast implants? Yes. Yes, it is. It definitely is. Absolutely. I mean, basically, not everybody, but the vast majority of people want natural-looking breasts. And it is absolutely possible. But what you got to do, XZDS5, I hope you don't mind if I call you XZDS5. what you got to do is not go on the internet and look at other people and listen to other people telling you what volume you should have and saying all this sort of thing. Because if you're quite small, if you're quite slim, then you're probably looking at a smaller volume implant, perhaps a teardrop implant, if you haven't got any breast tissue at all. And you might go away and then look on the internet and then you say, I'm going to have this volume. And they're going to go, what? You're going to have that volume? That's nothing. It's not worth it. You better have bigger. And then you get bigger and then you look round and not natural. So don't listen to other people is what I'm saying, because if you are quite narrow, if your frame's quite narrow and slim, you might be having a smaller volume implant to still get a good nice result. But on someone else who's been, let's just, I don't know, I know nothing about you, I've never met you, I've got no idea what your dimensions are, but let's just say you're looking at an implant of 150 200 cc, maybe, if you're very slim and very small and your frame's quite narrow, because that's what it's all about. It's all about the width. So you're looking at 150 200 cc to give you a nice shape. You go away and I've just seen your friend, and your friend, I've told them they're going over 300 cc to have a nice shape and a nice natural result, and you're like, hold on a minute, I don't want to be half as small as her. I want to, but your friend might be wider than you, and a 300 cc implant on her might give a similar result to 150 cc implant on you. So don't go away and talk to people and look on the internet about volumes and stuff like that. Go with what's right for your dimensions, because that's the problem with people who are very small. They and I've seen people who've been told, oh, it's not worth doing and all this sort of thing, and then they have it and they're very happy and they look great and they look, there's, it's certainly a tangible, significant difference, even though the volume of the implant might not be huge. But if their frame's not very big, then that's all their frame can take. Does that make sense? Anyway, the answer is yes, XZDS5, or should I call you _XZDS5? Yes, it is possible to get a natural result. Definitely. Lips on the double chin, could it leave excess saggy skin? Lips, not lips, I mean lipo. I meant lipo. Lipo on the double chin. Could it leave excess saggy skin? It could, Kim, and that is always the worry with liposuction, that it can leave saggy skin. There are some areas where liposuction works better than others, and the double chin is one of those areas that it does work well in that area, and the skin will often recoil. But it depends on how much skin is there, and certainly if there's a lot of skin, it may not recoil. If it's borderline, it might be something that is worth trying and seeing if the skin will. Come on, look at well, that you mean. It's what, blimey, O'Reilly. It's something that's worth trying and seeing what happens. Crikey, do I need it? Blimey, O'Reilly. Has that always been there? Or is that just since this question? Is there anything I can do with some exercise? I'm going to do some exercise to get rid of it. So yeah, it could be. I would probably try it if it's not too bad, and that's better. And I can't keep that up. Put my chin down. I would try it, and it makes it look bald if I do that. I would try it if it doesn't look too bad, and because then you're looking at scars if you're going to tighten the skin. Kim, I'm not you're going to send photos. You can send photos, Kim. What I'll probably do is I'll probably show them to Kurum, who does this sort of stuff. I don't do this sort of stuff on the face. Neck up's not really me. I do moles and stuff, but not really facial aesthetics. Anti-aging sort of surgery is not my bag. I'm more breast. I'm breast and body is my ting. _XZDS5 back in the house. When would I able to start weight training again post breast implants? So, well, this slight worries XZDS5 because you said you're very slim. And you said you're 32A, I think you said. So if you're very slim and not got much breast tissue, then I'm thinking putting them under the muscle to give it an extra layer of cover. This is something you would have to have with a face-to-face consultation to decide these sorts of things. But anyway, this is the sort of thing going through my mind. So I'm thinking under the muscle for that. And now you're saying weight training. I'm thinking, oh God, weight training. When you put it under the muscle, you get animation deformities. So that's something to be aware of. That you can get animation deformities when you put them under the muscle, and the recovery can be a little bit slower. Not dramatically, but then when you put it on top of the muscle. So that's just something in my head. But when will you be able to start weight training? I would say 4 to 6 weeks, gently, and you'd have to start gently because you're going to make it swell, and you're going to, you really need to let that implant get into pocket, particularly if it's teardrop. If you're using a teardrop implant, I'm going to say 6 weeks, because you don't want that any swelling, because the swelling around the implant can make the implant rotate. So 6 weeks for a teardrop, 4 weeks for a round, and then just gently starting to get back into it, just because you make it swell. You can do lower body stuff after a couple of weeks, but nothing with your upper body. Kim, thank you. If lipo is no good, would he tell me the alternative, please? And thank you. Yes, he would, Kim. And it'll probably be something like a facelift. A facelift will tighten the skin of the chin. So it's something to tighten the skin. So that's when you do excisional surgery. But yes. That was a nice little go. Any other questions anywhere? Now, I did see a question flash up on it on YouTube. I don't know if I'm supposed to have YouTube open. I didn't see it. I've only got Facebook questions here, I believe. Anyway, I'll have a look at it later. Was it on this? Oh no, it was on another YouTube video. Okay, sorry. Right. So that's me. I'm out of questions. If anyone's got any questions, then please ask them now. Or forever hold your peace until next week, Tuesday, 7 o'clock, right here. Any questions, post them to me on some kind of social media way. Email them to me, info@Staiano Plastic Surgery, STAIANO Plastic Surgery, all one word, .co.uk. _XZDS5. Is Kuram just as good as you are in doing breast implants? Yeah, he's just as good as me. He is XZDS5. The thing about breast implants, XZDS5, you will find, I mean, I don't know if you know this. This guy here. Yeah. Recognize this guy? Yeah, well, this guy right here has written a book on plastic surgeons and plastic surgery. And you have to find a fully trained plastic surgeon, and Kuram's a fully trained plastic surgeon. Now, we all have specialties, special interests. Pretty much all plastic surgeons do breast implants. And it's okay because, I think we're all trained to a certain level. So, I think it's okay that and Kuram is certainly absolutely fine doing breast implants. We all have our subspecialty interests. My subspecialty interest is breast. Well, that's what I did in the NHS. I did breast reconstruction in the NHS. Kuram's subspecial interest is cleft lip and palate. So he's a facial guy. So his face is his thing. But all plastic surgeons do liposuction, tummy tucks, breast implants and things. So he's absolutely fine doing breast implants. And I think it's fine to have any fully trained plastic surgeon doing breast implants. I don't think that it's wrong for plastic surgeons who specialize in other things to do breast implants. I would say you want to more think about your breast surgeon or your breast plastic surgeon when you're looking at breast asymmetries, when you're looking at revision surgery and things like that, complicated cases. Maybe you want someone who specializes in breast. But certainly for the normal breast implants, I think any fully trained plastic surgeon is fine. And Kuram certainly is a very capable, excellent surgeon, and I'm very happy for him. He works in my clinic, as you probably know, and I'm very happy for him to do doing breast implants. And I know that he's good because he's done loads. Hold on a minute, I've lost control. I sent you a picture on Insta about an FNG, free nipple graft, that is. Well, I have actually got another phone here, so I can have a look at that, Leonie. Let's have a look at that's you. I've got it. Advertise your book, as there is so many who don't know how to research a surgeon. Yes, do it at the start of every life. Do you think? Get my book. It's called Never Accept a Lift from Strangers. It's available from all good bookshops. I don't think it is actually. It's available from Amazon, $12.99, or Never Accept a Lift from Strangers.com, free. Yes, you heard me, free. I'm giving away free, $3.95 postage, or if you're near the clinic, pop into the clinic and we'll give you one. Clinics in Edgbaston in Birmingham. So yeah. So that's the book. Yeah, Never Accept a Lift from Strangers.com, I think it is, or .co.uk. Anyway, so Leonie sent me. I was wondering if a free nipple graft will be needed for my breast reduction. Well, Leonie, I've got your photo. I think maybe yes. It depends on the nipple to sternal notch distance, and it depends on how far you're moving it. And if you're moving it more than, I would say, 15 centimeters, then it's a possibility. And I think I'd be moving a long way with you, Leonie. So just based on that one photo alone, is that the question? Is a free nipple graft common on large breasts? I'll send you a picture on Instagram. Yeah. So in answer to that one question is, if I had to say yes or no, I would say may well be. I'm going to type it here. May well be, because I think that is quite a long transposition there. It's not common, no, Leonie. A free nipple graft is not common. It's only when the transposition is very long, which it would be on yours. So, blimey, people are joining. Should I do it? You can share it if you like. I don't mind. Shall I share it? I don't know. It's a bit weird. Shall I feel a bit weird, Leonie, sharing it. I don't know. No, I won't. Anyway, it's... Well, all right. Okay. Oh. Where's the camera? Oh God, that's all glary. Probably just as well. Anyway, it's a long transposition. Take my word for it. It's a long transposition. So yeah, you're looking at putting your nipple around 24 centimeters. So if it's sort of like 39, 40 centimeters from your sternal notch, where's my tape measure? So if you measure where your nipple is, put your tape measure, your sternal notch there, the notch where there, that notch. And if you're getting down to, 35, 40, then I think you'd be thinking of a free nipple graft. So no, it's not common. XDS5 is in. Have you begun to do GA procedures yet? No, XDS5. We're looking at doing some local sedation procedures, which is what I was saying about patients having sort of breast augmentations, maybe a bit of gynecomastia, liposuction, mastopexies, breast lifts and things. We can do under local sedation, but not GA. We are desperate to get into the hospitals. They said they'd give us some dates at the end of August, and of course they haven't. There's the phone. Right. Oh God, sorry. So Georgia Billings in the house. Nice to see you, Georgia. What's going on? Is anything happening? Oh, Fee's still here. Evening Fee. Sorry, I should have put that away. I wanted to know, here we go. I wanted to know if I would be able to breastfeed after an areola reduction. Yes, Salma, you can breastfeed after an areola reduction, assuming you can breastfeed before. But the areola reduction will have no impact on the ducts going into the breast because it's just skin you're removing. So that'll be absolutely fine. As I say, some people can't breastfeed, so that would mean assuming you could breastfeed before, it will have no impact on your ability to breastfeed. Interesting that I'm seeing so many women and men covering their neck when on virtual meetings. Have you seen an increase? Yeah, you know what? I don't do necks, but you would think, yeah, do you think that's a thing? On virtual meetings, I've only just started noticing it. I never, but now I look. Good God. Maybe you do some work myself. Honestly, I spent so much on this visage. I can't spend more on look at that. That's the thing of perfection. But yeah, we haven't seen an increase in neck lift inquiries. But well, Kurum does it, as I say, but it's not really the clinic is really based around the breast and body contouring, which is what I'm doing. I do notice it more and more. Yeah, well, I think I probably will now. I wish I hadn't started that, but yeah, maybe you need a. If all my things ended. Oh, my Instagram has ended. Is it worth going back? Is it worth going back? You're back. I'm back, Kelly. I am back, and I've just done. I get an hour on Instagram. It normally gives me a warning. I think have I finished? I don't know if it's worth going back. Has anyone got anything to say? WB4. Hey, WB4. Is that your postcode? WB4. Description. What should I put for description? Oh, I don't know. What have I just talked about? Interesting questions. There you go. Post. Yeah, well, I was actually going to wrap it up. I don't know whether I should go back onto Instagram. Should I go back onto Instagram? It's not gone yet. What were we talking about? Neck liposuction and Zoom calls. Yeah, that'd be interesting to see if neck liposuction is on the up because people covering their neck on Instagram, on Zoom. Here we go. Oh God, is that how I started it? God, live, start, checking connection. Are you having a great day? I'm back. There's no one on Instagram. I came back. There's no one there. I am WB4, but you know what? I'm struggling to get back into it because I've been off for 2 weeks. I'm officially back at work today, but I haven't been in the clinic. I've been at home, as you can see from my casual attire, and so I really, to be honest with you, I haven't done anything. I've got a website which has not working, which has been a cause of stress to me, which I've just ignored. And I read my book. I went into sat in the greenhouse and read my book for most of the day, to be honest. So I guess on paper it is a good day, but on reflection of what I have achieved today, very little. But I've got a clinic tomorrow, so I know I'm going to achieve stuff tomorrow. That's a good thing about a clinic. How Flowers in Capri? Good to see you all. I say you all. You. Was it Claudio? Who is it? Who's there? Nice to see you. Oh, Kelly's got a question. Kelly has a question. I have a question, but I'm not sure if it's acceptable. But how do you find out if a doctor isn't qualified or a specialist? I'm not. Oh, I'm not sure what terms doctor use. Kelly, where were you, girl? How do you find out? I don't even have to say anything, Kelly. What's this? What's that? What's happened? Extreme slow-mo. Oh. My bright light. Yeah. Never accept a lift from strangers, Kelly. This guy here has written a book. How do you find out if a surgeon's qualified? You read the book. You read the book, Kelly. That's what you do. No. It is a good question, Kelly, to the extent that I wrote a book about it. In short, Kelly, it is very much an acceptable question, and it is a travesty. Annalisa Raffaele. Oh, sorry. I get seagull. Sorry, Annalisa. Sorry. I was mixed up with seagull. I see seagull a lot. Nice to see you, Annalisa. So what you do, Kelly, in short, you look for FRCS Plast after their name. That is probably the easiest one. So you've got FRCS there. FRCS Ing and I'm going the wrong way. FRCS Plast there. Yeah. So FRCS means you're a fellow of the Royal College of Surgeons, and FRCS is quite a basic qualification. So FRCS is something that you get quite early on. So if someone's FRCS or MRCS, it is now, it was FRCS when I did it, then it became MRCS. That just means a fellow of the Royal College of Surgeons or a member of the Royal College of Surgeons. So if you're FRCS Ing, which means England, or there's a Scotland and an Ireland one as well. But if you're just FRCS, that's basic. You're looking for a specialty in brackets afterwards. And for plastic surgery, that specialty is Plast, P-L-A-S-T. For orthopedic surgery, it'd be Orth, O-R-T-H. For ENT, it'd be O-R-L, otorhinolaryngology. For general surgery, it'd be Gen, G-E-N. So if they've got 3 letters or 4 letters after the name, which is not England or Ireland, or I think there's Glasgow and Edinburgh, there's 2 in Scotland, then they are a specialist in something. They're fully trained. The other thing you can do, oh, here we go. I tried that on the website and it said they aren't on the register, but that's due to not working in the UK. Well, that's a bit worrying if they're not. So, oh, I see. So is it surgery abroad, Kelly? See, this is one of the problems with going abroad. That is one of the problems going abroad, because and that's something I talk about in the book about, one of the reasons about going abroad, because I advise people not to go abroad, not because I'm saying that all surgeons are bad abroad. Obviously there's good surgeons and bad surgeons abroad, and there's good surgeons and bad surgeons in the UK, but it's hard to know. Yeah, Prague. Well then, yeah, they won't be registered with the UK then. That is a problem. I don't know how to tell whether someone's fully trained in Prague, to be honest with you. And that is one of the issues of going abroad. There are other issues as well, of course, in terms of the traveling. If you have any issues, you got to find out what you do. If you have an issue back at the UK, can you see your surgeon again? What if you need a revision and all these sorts of things? But this doctor also worked. So you should be able to go to the GMC website, which is gmc-uk.org. So if you go to gmc-uk.org and it'll say check the registration. If you know their GMC number, 4117214 is my GMC number. But if you know the GMC number, you can put it in. If they know their name, if they've got a funny name like me, like Staiano, you should be able to search on their name. If they're called Smith, you might struggle, but if they've got a funny name, then there might not be many of them. So you should be able to check on the GMC website, and it'll say if they're on the specialist register. So they've got to be registered with the GMC. That's a given. All doctors have to be registered with the GMC, but you're looking for them to be registered on the specialist register. So there's a specialist register and there's a GP register. GP register is obviously for GPs. So when you finish your training in the hospital, you either become a GP or you become a specialist. So a specialist is either, as I say, plastic. It'll say specialist register for plastic surgery and from when. So that's another way of doing it. Look on the GMC website, but they should be on the specialist register. But if it is tricky when you go abroad, Kelly, and that is one of the reasons that you've got to be careful because of the issues in terms of aftercare, indemnity, training, backup from organizations like BARPS and BAPRAS, the professional plastic surgery associations in this country. You won't have any of that backup. What happens is there's a complication following breast implants. You get it fixed, XZDS5. So there's a revision policy. Your complications are covered for 30 days, which is sort of normal complications like infections and things like that. Let's say normal complications are not very common, but if they did happen, it's all covered. And then if there's also revisions. So revisions are covered. Revisions means if it doesn't look right, if one looks bigger than the other or what have you, and that's for 6 to 12 months depending on the hospital. So yeah, that's bad enough if you have a complication, but we hope to fix it for you if you do have a problem. Is it legal for normal surgeons cosmetics but not be upfront with the patients? I can tell you something now, Leonie. It's normal for lots of people to do plastic surgery or cosmetic surgery. Cosmetic surgery seems to be a term. Cosmetic surgery is not a term in medicine. In medicine, there are certain things you can specialize in: general surgery, orthopedic surgery, cardiothoracic surgery, neurosurgery, ENT, plastic surgery. Plastic surgery is a surgical specialty in its own right. Cosmetic surgery is not a surgical specialty. So a lot of people call themselves cosmetic surgeons, but they are not plastic surgeons. So, to be honest with you, a lot of people call themselves plastic surgeons who are not plastic surgeons, but you know, that's where we are. Kelly, I'm very nervous to book abroad, but it all leads down to the money. Also, it's a vicious circle. That's true, Kelly. I wish I could book with you. That'd be a dream. Blimey. It is a vicious circle, Kelly. And you know what? I don't know what to say. And I'm sure there's a lot of people who have surgery abroad and are absolutely fine and happy with it. And just if you weigh it up, you know. But yeah, it's a tricky one. But is it legal? It all the time. So that's why you got to educate yourself. And I think us as plastic surgeons